My name is David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center. Thank you for joining us today. Today's event is entitled For Nurses by Nurses, Nurse Endorsed Strategies to Address Nurse Retention. And it is co-sponsored by Academy Health's Health Workforce Interest Group and the Interdisciplinary Research Group on Nursing Issues, IRGNI. The mission of the Workforce Interest Group is to improve health and healthcare by promoting and disseminating evidence-based information that informs health workforce policy and practice. So if you're interested in joining our group, you may do so through Academy Health memberships. And if you do, you may use our listserv to share information, such as if your organization, institution has job openings, or maybe you just want to get some feedback on your latest research. So if this is something that interests you, by all means, reach out to Xiaochu Hu or Debbie Goldberg for more information. Now, concerning the upcoming annual research meeting, we do have a session at the annual research meeting entitled Caring for an Age in America, Addressing Workforce Challenges Through Research and Data. And this session, I believe, is on Sunday, June 8th. And so you're all invited to participate in that session. I hope to see you there in person. And if you're there in person, by all means, stop by our happy hour that evening. Like, it's also around 6 to 8. It's at Britt's Pub, which you'll hear about them again here in a second. And it's the happy hour. The social is co-sponsored by HWIG and the Public Health Services and Systems Research Group. So if you're in town, by all means, drop by. We'd love to see you there. Now I'm going to go ahead and turn our event over to our guest moderator. Today, we're joined by Kathy Sliwinski. Kathy, would you like to take over from here?
Sure. Thanks, David. Hi, everyone. My name is Kathy Sliwinski. My pronouns are she, her, hers, and I'm currently a postdoctoral research fellow at the Northwestern University Feinberg School of Medicine, and I'm also a member of IRGNI, and I'll be moderating today's session. So just to highlight a few upcoming IRGNI events, we also have our social event at Academy Health, which will be taking place on Friday, June 6th from 6 to 8 at Britt's Pub, and all are welcome to join. We can provide a registration link after today's webinar. We also have our pre-conference meeting happening Saturday morning, which includes a poster session, a fireside chat with 3 incredible panelists, and some podium presentations. And lastly, we want to spotlight the Emerging Diversity Leaders Program at Academy Health, which provides mentorship and community for underrepresented health services researchers. And they'll be presenting their work at Academy Health on Saturday from 2:15 to 3:30. So thank you all for joining us for this webinar on nurse retention. This webinar will address the growing challenge of nurse retention in healthcare and its impact on care quality, workforce sustainability, and organizational performance. We are so excited to welcome our 3 wonderful panelists. We have Dr. Regina Cunningham, Chief Executive Officer of the Hospital of the University of Pennsylvania, an adjunct professor and assistant dean for clinical practice at the University of Pennsylvania School of Nursing. We also have Dr. Jane Muir, assistant professor for the Center for Health Outcomes and Policy Research at the University of Pennsylvania School of Nursing, and senior fellow for the Leonard Davis Institute of Health Economics. We also have Gretchen Berlin, senior partner for healthcare systems and services and operations in public sector practices from McKinsey & Company. So now each of the presenters will spend just a few minutes sharing about their background, their journey to their current role, and briefly address their thoughts on potential strategies to address nurse retention. So we'll now turn it over to our first panelist, Dr. Regina Cunningham.
Thank you. Thank you very much, Kathy. I appreciate that introduction. Hello, everyone. Thank you for joining us. I'm Regina Cunningham. I'm the CEO of HUP, as Kathy mentioned. And just to give you a tiny bit of background on that, HUP is part of the Penn Medicine ecosystem located in Philadelphia, across Pennsylvania and parts of New Jersey. And the Hospital of the University of Pennsylvania is the largest among the Penn Medicine facilities. And the kind of care, it's a very large facility, about 1,000 beds. And the type of care we provide is very high complexity, high acuity. We also have a community campus located about 30 blocks away. I've been in the CEO role for about 9 years. And my journey into that role is kind of interesting. I never anticipated that I would do what I'm doing. I am a nurse by background. I spent many, many years doing clinical work, first at the bedside and then in nursing leadership. And my specialty area was in cancer nursing. I was always really interested in the role that nurses play and how they influence outcomes and how nursing services are organized and delivered. And so when I went to graduate school, I studied, nursing leadership. It wasn't called that then, but that is what it was essentially. And then I did my doctoral work at the University of Pennsylvania School of Nursing, and I studied the impact of advanced practice providers on clinical outcomes in men undergoing radical prostatectomy. At the time, it was a long time ago. And then I have worked in sort of a series of progressively responsible nursing leadership roles over the years. And I ultimately became the chief nurse executive where I am now at the hospital of the University of Pennsylvania, and then the senior vice president for nursing across all of Penn Medicine before coming into the CEO role here. And it's a different kind of role, but it does offer a really nice platform, a much broader platform to drive positive change. So it's been like a fun journey, I would say. Just wanted to share a couple of sort of thoughts and key potential strategies to address nurse retention. And I think, one of the key things as we think about this as leaders is that we do really need to understand within the organizational context what we believe the drivers are so that we can develop specific strategies. So there are some, general strategies that you see sort of across the nation, but then there can also be some organizational specific things that I think are really important to pay attention to. And in order to know that, thinking about surveillance, making sure you listen to what the struggles are, what are the challenges that nurses are facing, and then really begin to try to address those things so that you don't lose people based on things that you could try to relatively easily fix. Just to give you a quick example of that, in Philadelphia, it's sort of the epicenter of a lot of the drug crisis in America. And so we have many, many patients who have substance use disorder as a comorbidity. And one of the big challenges that we were seeing among our nurses was a fear, really, just a lack of confidence in the ability to manage some of the complexity that was associated with this population, like xylazine-induced wounds, and how to manage patients with these complex problems. And so our chief nurse executive, Colleen Mattioni, collaborated with the University of Pennsylvania School of Nursing to engage some of their expertise in helping us to establish some competencies around this and some education, and for nurses to be able to be more competent. So that's been like a strategy that's been really helpful in addressing that issue. But listening to nurses and understanding what is driving the turnover is really important. Another challenge, and this is more of a national challenge for sure, is thinking about the experience complexity gap. And I think that this really does threaten nurses' ability to deliver very safe and high quality care. And it really also threatens access, because when you think about the challenges of high turnover, access becomes a big issue as well. So the experience complexity gap occurs when new to practice nurses can't manage the complexity of what they find in the hospital setting. And I think probably many of you are aware that since the pandemic, we've had an increased number of challenges in the acute care setting. One of which is that we're really seeing sicker patients, right? Our case mix index is going up, severity of illness is going up, and that creates, challenge for new to practice nurses. And when I say to new to practice, I mean less than 18 months of practice, right? Because they don't really have the skills yet to manage all of that. They don't have the competencies. So now at the same time, the great resignation that we saw post-pandemic caused a loss of a lot of experience from our hospital settings, right? Many experienced nurses turned over, and that created like the gap in terms of the experience. And that really disrupted, what is often called a community of practice, a way that nurses learn once they get into the practice environment. And those existed historically, in acute care hospitals. So I think, that creates a very, very heavy burden on the remaining nurses that are in the hospital setting, right? So then that exacerbates it in the sense of, these fewer experienced nurses have to precept and they have an increased pressure on them. And then that can also create dissatisfaction among that group and burnout. And so that is really, it becomes like a cycle that's really challenging. So thinking about how we can address those things in partnership with schools of nursing and, with other groups that are providing basic nursing education, I think is really, really important. But those are just a few sort of quick thoughts about some of the challenges that we're seeing. I think that at the Hospital of the University of Pennsylvania, we actually have done quite well with nurse turnover over the years. We're actually lower than our pre-pandemic rates. And I think part of it is just really staying in tune, trying to stay very close to what the challenges and issues are for nursing, and then trying to just make sure that we are developing programs and providing resources that really support them. So I will stop there. And Kathy, I'll turn it back over to you. Thank you.
Great. Thank you so much, Regina, for those initial thoughts. Our next panelist is Dr. Jane Muir.
Thank you, Kathy. Hi, everyone. I'm so thrilled to be here. Thanks for the opportunity to speak with you all. I am an assistant professor on the tenure track at the University of Pennsylvania School of Nursing in the Center for Health Outcomes and Policy Research, and also in the Department of Emergency Medicine at Penn Medicine. I am a nurse researcher. I'm a former emergency department nurse, and I currently am a family nurse practitioner at Puentes de Salud in Philadelphia, which is a community health clinic that serves uninsured Latinx patients. I spend most of my time as an assistant professor doing research on issues facing the nursing workforce, including nurse burnout, intent to leave, job dissatisfaction, departures from healthcare jobs, retention is in that umbrella as well. And my work examines how nursing care is organized in hospitals in order to optimize nurse well-being and retention, and also to optimize patient care outcomes. I've always been very interested in the well-being of nurses, and it's actually how I got into research. Actually, what started my work in this field was a meditation class in undergrad. Before I even was a clinical nurse, I took it because I thought it was going to be a chill, relaxing elective, and it ended up being pretty transformative for my career. We were required to do a lot of empirical research reading around the stressors that nurses face, the burnout that they face, what are the drivers. And I was really intrigued by the idea that work environments could be transformed to support nurses better for their well-being and for their intent to stay in their job for these issues of retention. I have experience with retention projects and research at the local hospital level and also at the state and national policy levels. And so I've learned a lot. I've learned a lot from both perspectives. I have experience understanding the reasons nurses may be interested in individual strategies to support their well-being and retention, as well as larger scale national and state policy approaches. So just a few examples. As a practicing nurse, I conducted several research intervention projects focusing on improving nurse well-being at the individual level for about 8 years. And a lot of that work was pre-COVID, providing in-the-moment mindfulness-based stress reduction interventions to clinicians while they were at work operating in high-stress work environments. So that was bringing meditation to nurses on the unit, organizing retreats outside of work for health systems around clinician well-being, delivering them through apps, developing virtual reality interventions for nurses who need to take brief breaks but don't have the space or time to do it in a chaotic work environment. On the other end of the spectrum, I have experience studying the effects of large-scale policies that enact systemic change to improve nurses' well-being and retention. Things like nurse staffing legislation that would require hospitals to staff enough nurses safely at the bedside. So this work encompasses policies that require, for example, transparent reporting of nurse staffing ratios at the national level to allow the public to be informed of the resources of nurses in hospitals. And it's also informative to nurses who have an interest to work in hospitals where they know they're going to work in a safe environment with enough staff that they're working alongside, because we know that staffing is associated with nurses' burnout. So by providing nurses with sufficient resources in their workplace, a lot of my work looks at these policy interventions that can impact nurse well-being and turnover. And so having led both types of interventions, I don't think it is an either or type selection, but I do think, as Dr. Cunningham said, we need to listen to what nurses say that they need to reduce their burnout and improve their well-being and to stay in jobs in healthcare. And consistently, what we know from the research is that they prioritize over individual strategies, these policy level ones that are ensuring that nurses show up to work and they're safely staffed, that they feel supported by their unit management, that they have autonomy in their workplace, that they have involvement in the issues that are contributing to their stress and burnout, like they're involved in committees that can address the workplace violence that makes them feel safer when they come to work every day and that they want to remain in that workplace. And so those are some high level points that I'm involved in with my research and from clinical practice. So thanks for the opportunity to be here.
Thank you so much, Jane. And then I'm going to turn it over to our next panelist, Gretchen Berlin.
Hi, thank you so much, Kathy. Thanks for having me here, and to Regina and Jane for sharing their insights. I am a nurse by training. I also went to the University of Pennsylvania. There's a very common thread here for Philadelphia. But I also got a degree in business, and I was an administrator at the National Health System over in the UK for a bit, but I've actually spent most of my time at McKinsey, which for those of you who aren't familiar with McKinsey, we're a global consulting firm, and we work across industries, but within healthcare do work really across the value chain. And so I, along with colleagues, have the pleasure of being able to help health systems and others try and improve the effectiveness and efficiency of care delivery. I lead our work at the intersection of healthcare and operations, including a team of about 40 nurses that we have now. And we work with health systems on everything from recruiting, more efficient staffing and scheduling, to many aspects of retention. And so have seen different strategies across the country and a bit, honestly, across the world, where we actually have a lot of similarities of challenges and potentials to learn from one another. I think Regina and Jane shared a lot of perspectives on retention and how to think about it that I won't repeat, but I would just say that the things that we have found consistently in the research and publications that we've done on the topic are really in a few categories that I would call out. One is on workload and the balance of staffing and team environment that Regina was alluding to, but also ways that workload can be either appropriately distributed among team members or even, especially in most recent years, supported through technology. And so we did a report a few years ago with the innovation arm of ANA, where we estimated in the inpatient setting that up to 20% of work that nurses are being asked to do could potentially be automated and another 10% delegated. And that's not to say that you could, lower the number of nurses, but actually take that burden off of them, which we know that level of stress is leading to turnover. The other part of workload I would call out is just the flexibility in it. So only about a third of nurses that we survey, in particular in the US, believe that their employers are offering flexible scheduling options. And I think these take several forms, whether they're shifts, whether they're sites of care, whether it's leaning into virtual and physical kind of job requirements. But the flexibility, I think, is increasingly desired, particularly among younger generations. And then the other piece I would call out is really just the leadership support and environment, not just for frontline, but also for nurse managers. So we actually published for Nurses Week a few weeks ago a focus on this and how to really ensure that nurse managers are getting what they need so that they are staying in role and that younger generations have a desire to move into leadership. And I would just call out, there was research, I believe about a year ago from AONL with Laudio that really showed an empirical link between when nurse managers turn over and a direct uptick in turnover of frontline nurses as well. So would just underscore really those two of workload and leadership and environment.
Thank you, Gretchen, and thank you all for those opening remarks. I think there's so much more to talk about with these amazing panelists, so let's get into some questions. We'll start with a few prepared questions and then open up the floor to some audience Q&A. So everyone in the audience, you can already start typing your messages in the chat, and we'll be getting to those soon. Our first question for our panelists is if you could describe how you've seen nurse retention challenges evolve in the past 5 years, especially post-pandemic. And I know, Dr. Cunningham, you alluded to some of these points already, but any additional thoughts to add from any of the panelists?
I'm happy just to throw out some statistics. So I think one thing that I've always found fascinating is the direct correlation of nursing turnover to the economy. So there's a direct link between unemployment, and for every 1% decrease in unemployment, there's almost a direct 1% increase in nursing turnover. So there are some of those macro factors at play, but there is just, as Regina was alluding to, obviously a huge spike in turnover during the pandemic and kind of through it, which has come back down and settled honestly at a level even a bit below pre-pandemic, which is great. And as we had been surveying on intent to leave, it was quite high and consistent at about 30%. And that's in our most recent survey actually come down to 20%. So I think that is quite promising. The piece that gives me pause, and I would love my panelists' perspective on this, is just some of the qualitative things you start to hear around the environment, as I mentioned a bit on kind of leadership and support, but in particular around safety and some of the fears that Regina was alluding to, but even just the physical fears, which is hard to quantify, but I think is a real undertone in society in general, but shows up in our healthcare settings, unfortunately.
Yeah, I mean, I think those are great additions, Gretchen. I definitely think the issue about workplace violence is very, very real. I mean, being in a place, and again, being in Philadelphia where there's a high crime rate, a high rate of gun violence, and I think just in general, and again, you alluded to this, Gretchen, society it's more challenging than it was like pre-pandemic. I would say that, the tensions that exist for a whole bunch of different reasons in society, I think are playing out when we see people in the hospital. They're probably at their most vulnerable. I mean, for a lot of these people, they're in a horrible situation. And so you have all of that all those factors kind of at play. And organizations do really need to make the investments in the workplace violence initiatives and interventions, because that does really, really matter to patients. I mean, we hear that from nurses like all the time. In terms of like quantifying it, hospitals often do something called a culture of safety survey. And there are some elements that, probably reflect to a certain extent those variables that people are concerned about. It's not probably a direct measurement, but it is at least a way to sort of see where you are and what your progress is over time with regard to any interventions you might put in place, their level of effectiveness.
I would just extend what Regina said by emphasizing that workplace violence is certainly an issue that's emerged since the pandemic, and we've done some qualitative and quantitative investigations of nurse workplace violence experiences, and it is very much affecting the younger cohorts of nurses. When we think about the ones that have just entered the profession, it's certainly something that that is driving them out of healthcare jobs. About 10% of nurses between 25 to 32, and when we looked at top factors why nurses left in recent years, workplace violence was that driver. And so just reinforcing what Regina said, that, there's actually no national universal standard for hospitals published by NIOSH on what you need to do for workplace violence prevention. And I think it's really in hospitals' hands to come up with their game plan to improve that safety and to invest in those prevention strategies, because it's certainly a contributor of nurses not feeling safe in their workplace. Safety in general, whether it's because of inadequate staffing or feeling fear that you're going to show up to work and be punched, kicked, assaulted in some way. These are all reasons why we have some retention issues. And then going back to Gretchen's sort of overview of the trends in the pandemic, we know that the supply of nurses dipped in the beginning of the pandemic and has sort of, now I think David Auerbach published in the JAMA Network that they're even projecting a surplus of nurses potentially in the next 10 years. And so I just want to emphasize that when it comes to the nursing workforce, it's less of an issue of our supply right now, like needing to expand our pipeline of nurses, and more of we need to strengthen the retention part of this. And obviously that's why we're all here today. And so when we look at the retention challenge, when we look at why nurses wanted to leave before the pandemic, during the pandemic, and after the pandemic, there were a lot of commonalities. It's a lot of these systemic issues and systemic challenges that nurses said, this is why I'm not going to stay here. Insufficient nurse staffing, feeling so constrained and emotionally exhausted at work that it's driving you to burnout, not feeling supported or valued by your employer. And so there are things that have changed since the pandemic, like the issue of workplace violence and that consumer-facing issues. But there's at the same time really consistent systemic challenges that I think nurses are getting sort of fed up of seeing over and over again.
I agree with that. I would just add, I think a lot of these systemic challenges were in place before the pandemic, and the pandemic just shone a light on it, but sustained. The only other piece that we haven't mentioned that I would call out is the site of care proliferation as well in healthcare, which was happening before the pandemic, but has continued, increases the demand and places for demand for clinical staff of all types. It's not just nurses, but I think it puts strain then on each care setting and exacerbates some of the underlying tensions that Jane was speaking to.
Thank you so much for your insights. We're going to go through one more prepared question, and then we're already getting lots of questions in the Q&A and chat, so we'll get to those next. But I'm wondering if you guys could talk about what specific initiatives have health systems, organizations, or even other countries or regions in the US have implemented that have shown measurable improvements in nurse retention that we could learn from.
I'll start. Like I said, I come through to this issue with a policy lens. And so a lot of the initiatives that have gained traction from a legislative and policy perspective have to do with ensuring that hospitals are staffing enough nurses within hospitals and healthcare settings. And so one example of that is mandated nurse staffing ratio legislation, which would require that hospitals staff enough nurses to a specified ratio across different types of settings. So one example is 1 to 4, 1 nurse for every 4 patients in medical surgical units, 1 to 2 in the ICU. And so speaking of the pandemic, I think after the pandemic, we actually saw more states introducing legislation around this nurse staffing mandate topic. And California was the first state to implement and enact this legislation in 2004. And so since that time, we've studied California nurses at different time points since that implementation. And we consistently find that compared to non-California nurses, California nurses consistently have lower odds of burnout, lower odds of job dissatisfaction and intent to leave. They feel supported by their employer. They feel safe in their workplace. Obviously, there's other factors that you have to think about. There's union considerations, there's wage, cost of living considerations. But I think as a policy, it's an interesting and it's an empirically based and it's important factor to consider, either introduced on a policy level or introduced by hospitals themselves who choose to staff to have certain local level policies where they're staffing enough nurses. The reason it's an important thing to consider as an initiative and an intervention is that when we do surveys, we do national surveys of nurses at Penn every few years, like consistently, the number one thing that nurses say in terms of why they left a healthcare job is because they didn't feel like there was enough staffing on their unit, insufficient staffing, feeling constrained. I'm caring for too many patients at a time. And we've also studied nurses who've not just left one hospital to go to another, but have left healthcare overall, which is very troublesome. And qualitatively, they'll say, I would have worked another few years in healthcare if I had felt, if I had worked with safer staffing ratios. And I think there are some interesting care models that have emerged. One of them is virtual nursing. Virtual nursing is where on a healthcare unit, nursing staff are hired to be a support for the nurses physically at the bedside to help with medication documentation or admissions and discharges. And these are interventions that have been considered to not only offer nurses another type of like mix up the type of job day that they have so they don't have to work just in the unit every single day, but they could also work virtually. But it's also, when we talk about technology to reduce workload, it's aimed at sort of diverting some of that or delegating some of those tasks to virtual nurses, to other nursing team members. So just from preliminary research that we've done, it's kind of a mixed bag right now in terms of what bedside nurses think of the virtual nursing model. Some find it to be very helpful in reducing their workload. Some find it to be very redundant in terms of, I have to go double check what the virtual nurse did and I'm fixing a lot of errors. They're not super familiar with our procedure for doing X, Y, and Z. The nurse wasn't available when the patient fell. And so I think these are, that is a tech-based innovation that's being considered to divert, delegate nurses' workload, to offset nurses' workload, that I think we need to study more closely. Thus far, it's kind of showing that it could be an added workload, maybe not, maybe. And so those are just some high-level initiatives that I can think of to share.
I can add an example that we've used here at the Hospital of University of Pennsylvania. So one of the challenges that I think, we talked about the nurse manager role. That's just a really, really challenging role when you think about it, yet it's such a critical role in hospitals. But all frontline nursing leadership roles are really, really critical. And a lot of times, I think we put people into these roles and they're not always quite ready, or they don't have all of the skills that we might want them to have when they go in. So one of the programs that was developed here by our Director of Ethics, Eliza Narva, she's a nurse and an attorney, and she developed a year-long ethics fellowship, but ethics in the broad sense, ethics that includes a lot of training and skill building in the areas of communication, interprofessional communication, mediation, those kinds of things. And a lot of times I would say that in a complex environment, nurses are challenged with situations that they're not really sure how to resolve. And so these skills come in to play, and they have been really, really effective. And so part of this program involves, didactic, and part of it is more experiential and role playing and learning how to diffuse some of the complex situations that occur often in an environment like a hospital environment where the stakes are really high. There's a lot of tension at times. And this descriptive paper is actually in the draft form, which will be published. And I won't give away the whole thing, but in general, I would just say that we have seen really improved outcomes among our nurse managers and other frontline nurse leaders as a result of this skill building. And I think something like that goes a really long way, because one of the things that can be so frustrating, and it's some of this is just related to complexity, some of it's related to technology, some of it's related to just misunderstanding of roles and things, but there can be a lot of tension interprofessionally in the communication, and that's hard for people. I mean, it's really hard. And when it works well, it's a great source of joy. And, it supports well-being for nurses when you're working with colleagues, to resolve issues, on behalf of patients and their families. When it doesn't work well, it creates just a lot of tension. And so having the skills to be able to navigate that effectively, I think goes a really, really long way. So, so that's an example now that it took a lot of effort to put that in place and to maintain it, but it's been a very, very successful intervention in building skills. And every single frontline leader that has gone through that program has been retained. So there'll be more data, in the publication when it comes out. But I would say the preliminary results have been really, really impressive. And so that's important to put things in place and evaluate their impact on, on these key variables. Thanks.
A few others that I would add, just that we've seen publicly cited. So in the spirit of mentorship and getting at the different tenures to the community of practice that I think Jane was mentioning, a lot of systems have either done formal residency programs for newer nurses, but also really doubling down on mentorship. So Mass General Brigham has really done this with, I think it's 3 months. They do all of their new nurses meet every 2 weeks with more tenured folks for deliberate mentorship. On the flexible work options, a lot was written about Mercy Health during COVID. I think they were one of the first ones to really break the schedule options, allow people to come back and opt in. Others like Henry Ford and Northwestern have done that too, and I think all three have shared publicly real improvements in their retention. And then there's a bit on tech-enabled leadership support too. Nebraska Medicine is one that we cited in the nurse manager report I was mentioning, that uses technology to help leaders be the leaders they want to be, in terms of just nudges around, this is the staff's anniversary, they've worked X number of shifts overtime, you should check in with them, kind of thing. To the point on global, as I said, anytime we've looked internationally, and I'm sure Jane, you all have too, the kind of developed countries have very similar trends of turnover and intent to leave. And one of the interesting things that I think other countries are doing a bit more than in the US is trying to get more upstream on prevention. So, community-based nurses and using community health extenders kind of with nurses to try and prevent more volume coming in. And two, leveraging more family members and kind of whole community in care outside of just healthcare professionals, that I think they probably do a bit more than we do here. Although I know there's some pilots with like a neighborhood nursing program happening in Baltimore, for example.
I'll build a tiny bit on Gretchen's point about the residency. Another strategy that I think there has been a number of publications on, and something we've put in place in specific programs here, is around advanced practice fellowships. So that actually, for people who are new to practice at the advanced level, I think has been a very, very helpful strategy as well, where they're just getting a lot of support. There's a didactic component and then an experiential component. And I think that really helps to prepare people to have the skills and competencies at that level. And that's really helpful in terms of retention as well.
I just wanted to add one more point to these excellent points and say, I still think across hospitals, we can do a better job of the transparent reporting of the turnover rates and the burnout. I think that's something that some hospitals started doing more during the pandemic, because fortunately for all of us who care about this topic, like the topic of burnout and turnover became more the public was more interested in it, and media was reporting on it. And so I think organizations were more interested in being open about reporting some of these issues. So I think in order to move the needle on things, if you can't measure it, you can't take action on it in a way. And I think we need to hold more hospitals accountable across the US. I think some hospitals, Penn is a very strong health system. They're like such a high performing health system when we do research on them. But I think across the US, if we can hold hospitals accountable to report more about what the turnover rates are for nurses, or even if we can find ways, there's some controversy around measuring nurse burnout and whether nurses feel comfortable revealing that to their hospitals. And so even at a national level, CM Hospital Compare has been a place where, through Nursing Home Compare, they've transparently reported on nurse staffing ratios in nursing home and long-term care facilities. And I think that's something that in the future we could demand from a nurse staffing, general hospital nurse staffing ratio reporting, turnover reporting, so that we can know the progress that we're making on this issue.
Great, thanks. We're going to transition into some audience Q&A, and everyone, you can keep dropping your questions in the chat or in the Q&A option. So one question we had is about leadership support and how we've kind of talked about that as key to supporting nurses. And one of our audience members is asking, can you provide some examples of how leaders could show their support? We talk about listening to nurses regarding their concerns, but how are we doing that? How are organizations gathering that information from nurses? Does it look like town hall meetings or surveys, or what are some effective strategies to actually hearing from nurses and then using their information to create interventions?
So, I mean, I can start. I mean, I think, yeah, town halls and surveys are all good, but I also think leadership visibility and direct interaction with nurses is absolutely critical. Just to give you sort of an example, I will round on units, go to visit nursing units. Sometimes I meet with them in a formal way and I'll sit down and talk with them. Other times it'll be a little bit more informal. I mean, one of the issues when I was just mentioning about the ethics fellowship, and the communication, interprofessional communication, one of the things that I know is from making rounds, and I repeatedly hear from people that technology is a barrier to people communicating well. Like, for example, almost every time I go, I hear from nurses that, the people are texting about a patient issue and they're, standing 10 yards away, but they're still texting. And so, that kind of challenge is something that you can address. I think hearing directly from people, and I'm the CEO, I might round with another senior executive. The CNO here will also round. Nurse managers need to do that. I think having empathy, understanding, empathy is like a superpower, I think, when you're working with people, and just making sure that that they feel cared for, that they're engaged, that you ask them for their opinion, and then you close the loop and get back to them on issues. A lot of times, people will ask me things I don't have the answer to, but I will get back to them. I will circle back to them with information, and I think that that's really important. So it's a multi-pronged approach, I think, to showing nurses support. I also think, as a person in my role, one of the key things I do is to allocate resources, right? So that's a very, very tangible way of showing people support when you make investments in, evolve systems for workplace violence, in fellowship programs, in staffing, as Jane, highlighted a number of times. Those are very, very tangible ways to demonstrate support, and they're critically important to point out to people so that they recognize, because when you make an investment in something, a lot of times in American hospitals across the country, it means you're not going to make an investment in something else because there's a finite amount of resources. And, at least 2/3 of the hospitals in this country have not fully recovered financially from the pandemic. And so I think those are just a few thoughts that I'll share.
I'll just underscore your comment about obviously your rounding, but others rounding too. And I do think one of the benefits of the pandemic exacerbation of all of these issues is if it wasn't already on the radar screen of CFOs and CEOs and COOs, it got there. And I think the more that it stays there and folks continue to round and get direct feedback, not just from nursing leaders. Obviously, nursing leaders are critical, but the whole executive team, I think, is critical. And I would also just emphasize your point about kind of direct response and feedback. So, as a leader, thinking through what are the big rocks that need addressing but are going to be harder over time versus the easy switches that can happen, and discussing that as a leadership team to really make a point of doing it for visible progress, even if it's the small things. And then one point you didn't hit on, but I'm sure Penn has, is just the shared governance approach in terms of engaging the front line really formally in the blood flows of the formal decision making, aside from more of the ad hoc that we were speaking to.
Yeah.
Great. Go ahead, Regina.
I was just going to say, like, another strategy that we often use is like the use of huddles. to transmit information. And I mean, there's evidence that demonstrates that doing that, it does really make a difference for people. So again, it's usually a direct strategy. You're going to transmit certain information. You have the opportunity to hear whether people have questions. You can respond to that. And it's a way to drive performance in the organization, but also to drive engagement. And again, I think it's it's a quick strategy. Doesn't take a lot of time, but it is empirically based and something that I think a lot of units use.
Yeah, I'll just underscore what both have said, that when we hear from nurses and even from firsthand experience, nurses spend a lot of time documenting near misses, errors that happen on the unit. They have sort of reporting mechanisms that they do when there's a workplace violence exposure, or maybe there's a whatever injury. And I think underscoring what Regina said about empathy and closing the loop, same with Gretchen, closing the loop on communication, it makes a huge difference for a leader to follow up with the nurse and check in. How are you doing from this experience that you've had? I'm not coming at this with a punitive lens. I just wanted to check in on you and see how things are going and monitor. You would be surprised how many nurses write to us in our surveys that that's not happening. I was trapped in a patient's room and I was terrified and couldn't get out of the room with a violent patient. Emailed so-and-so, never heard back. And so I think all of the strategies that both mentioned underscore this need for nurses to be heard. I think the issue is that nurses do not feel heard with their concerns and that they're valued by their leadership.
I think also the last thing I should have said earlier, but making sure that there's a nurse voice in the environment too. So to the extent they can participate in peer interviewing for folks who are joining the team, in upward reviews or input into who gets the advancement, can just help for overall kind of team composition. Even if it takes a little bit of extra time or it means non-productive time for a nurse to participate in the interviews instead of on patient care, it's well worth it in terms of investing in the environment, which will pay back in retention, let alone quality.
Great. Another question we have is from Dr. Dan Keller at the Mayo Clinic. They say, great talks. What are effective interventions to improve nursing work environments? What are strategies to get buy-in from frontline nurses and upper leadership to ensure these strategies are implemented successfully and sustained over time? We've talked a lot about staffing ratios and some shared governance models, but what are some other interventions to directly improve nurse work environments?
I feel like we hit on a lot of them in the last question. I think maybe the one angle that we didn't speak to is back to my earlier comment that technology is rapidly hitting us. And it can't just be, another app, another technology thrown at staff, but really investing in having some representation, at the right level in development, either in development of the product or at least in development of how it's going to be rolled out in the institution. And obviously not everyone can be involved in that, but at least having a representative in that voice who can bring it in will go a long way in terms of actually creating the change that is desired through, whether it's technology or something else, but through an initiative, and also just the receptivity of it from an environment perspective.
Jane, did you want to go? I want to underscore that point about technology. Because I think we don't leverage technology the way other industries do yet in healthcare, and that is critically important. But I want to go back to something you said earlier, Gretchen, that really struck me as being critical, which was, making some of these roles, making young leaders want to go into leadership roles, right? And I think that the selection of our leaders, the identification selection of the right leaders is critically important, because when you think about what controls the practice environment at the local level, which is, where culture unfolds or tends to unfold in a hospital, that frontline leader is so key in what how that environment works. And I think that, so it's the selection of people who really have like the right skills or attitudes, and then really developing those people, because there are so many leadership skills that are critically important to success. in some of these roles. I think we really have to pay attention to the development of our leaders. And then that makes it like a more exciting opportunity for people. They know they're going to be developed, but it's not just sort of like the hardcore leadership skills, but the development of emotional intelligence and how that's cultivated within an organization makes a huge difference in leader success. And so I think thinking about that, because those are the kind of leaders who are going to cultivate the environment and the culture that you really want. The people who can communicate up to get the resources that are required, and the people who can communicate in a very effective way with the teams on the unit. And that's a skill, because middle management's just it's a tough role. And we really, really have to make sure that we are selecting the right people and then really helping to develop them in a way that really makes them feel good about the work. And that translates into like how the nurses and everybody else on that unit really kind of feels, because they're cultivating or creating that environment in a very powerful way.
The only thing I would add, zooming back out at the policy level, is, again, nurses we're the largest healthcare professional group, but we are so often on the chopping block when you think about healthcare being a business. Labor is expensive for hospitals, therefore we are often on the chopping block, and that has serious considerations for not just nurses' retention, but the safety of the public, because we know that nurses are providing the majority of direct care and surveillance and advocacy. And so what I would just add to both, overview, both contributions, is that we need policies that provide safeguards around the configuration of nursing in our healthcare settings at a state and national level. And so when we talk about making sure that nurses are at the table, it's in our hospitals, but it's also in our legislative state houses, it's lobbying, it's reinforcing the organizations that represent nurses, NINR, ANA, making sure that our voice is heard in those arenas, so that when challenging political times arise, when challenging times arise in hospitals, that nurses have a voice, so that we continue to be abundant, because we need to have safe ratios for nurses to provide the best care possible. So that's just something that I would underscore. And I shared examples of state nurse staffing ratio legislation, transparent reporting of the adequacy of resources. I think that one thing I wanted to add on an international level is I don't know if you all have seen that British Columbia is trying to do a sort of like recruitment of American nurses to British Columbia hospitals, with the promise that we have a legislation brewing that's safe nurse staffing ratios. If you come to our hospitals, we have legislation coming soon that would put safeguards around the number of patients that you care for at a time. So I think that's an important recruitment strategy, meaning that they've sort of tuned into what nurses want in their healthcare environment, which is safety.
I would add to that. I think excellent observations, Jane. On the labor issue, the expense, labor, always being looked at as an expense and something to be on the chopping block. I think that there does also need to be payment reform on nursing, a different way of looking at nursing. And I know there's been obviously some literature about that. It was addressed in the Future of Nursing report published by the National Academy of Medicine a couple of years ago. But that decoupling from sort of decoupling nursing from housekeeping within hospitals is a big opportunity. And I think that we need to take a look at that. And then I couldn't agree with you more on the legislation. I think, we still have many states, Pennsylvania included, that don't have full practice authority. And that these are, barriers that don't need to exist. And we do need to continue to try to address these issues. Yeah.
Thank you so much. I think we're going to have time for one or two more questions. So another question we got is, how do issues like equity, inclusion, and discrimination impact nurse retention, particularly among underrepresented groups of nurses? And what are some strategies to address those disparities?
I'll just say, speaking from the literature, I mentioned that workplace violence was a key reason why nurses left healthcare jobs in the past few years, and experiencing horizontal bullying and racism and discrimination was one of those specific causes. And qualitatively, that has been reinforced with nurses saying, I've experienced micro and macro aggressions, discrimination from my colleagues. Our collaborator that many of you know, Dr. Margot Brooks Carthon, she's a leading health disparities researcher. She's published a plethora of evidence showing that nurses from racial and ethnic minority backgrounds experience higher odds of job dissatisfaction and burnout and intent to leave compared to their white colleagues. And so I think that, and that work has been reinforced certainly in the sexual and gender minority literature as well. And so I think it just reinforces that when we speak to these nurses about strategies that can be considered, I think nurses want to see a more diverse workforce. We have a lot of work to do in terms of recruiting more racial and ethnic marginalized people into this profession. I don't think nursing from a demographic perspective represents fully the populations that we serve in our communities. And so I think there's a lot of progress that can be made there. Dr. Sliwinski does a lot of work on patients who experience language barriers in the workplace and how language concordance between a provider and a patient is extremely important for care outcomes, yet we don't have nearly as many multilingual clinicians to provide that workforce support for those patients. And so I think there are interesting strategies. The first thing that comes to mind is the magnet designation, the magnet hospital model. Magnet hospitals are those that are known as for having excellence in nursing. They have shared governance models. They have opportunities for nurses to progress and advance. There are opportunities for nurses to do research. The hospitals are involved in research, interprofessional collaboration. I think built into the magnet model, we can look for opportunities for nurses to learn more about their patients from diverse backgrounds, ways to recruit, hold hospitals accountable to recruit a diverse workforce. Can we offer like language opportunities for clinicians who want to learn languages other than English to support their patients as much as possible? So those are just a few things that come to mind.
Thank you so much, Jane. Gretchen, sorry, you unmuted. Did you want to add something?
No, I was going to say, I think Jane covered it very well. I'm not sure there's much to add.
Yes, she nailed it. So I think our last question, maybe just to hear like a minute from each of you, what can attendees of this webinar, some of us are clinicians, researchers, future administrators or policymakers, do now to contribute to better nurse retention outcomes? And we'll just kind of leave it on that.
I'd say if you live in the state of Pennsylvania, write to your legislator to support the Pennsylvania Patient Safety Act, which is being considered in the Senate, and that would hold hospitals accountable to staff nurses safely in their hospitals.
I would just say use your individual voice in whatever role you're in. Obviously I'm not practicing, and I have found it quite interesting to see there's nurses in all kinds of different roles. Obviously some practicing, some in direct kind of clinical leadership. But I think bringing this issue, which affects every single person in the world really, to whatever table you're a part of will just help continue to shine a light on it, which we'll all need.
Regina, you're muted.
You know, somebody had to do that during the webinar, so it had to be me. So I was just going to say that in addition to what my colleague said, I think, one essential thing is to make sure that you are communicating and that you're communicating with people about what the challenges and issues are, and that you're learning from your colleagues and that you speak up. So the point about using your voice, being heard, I think are really, really important things. You can find out a lot from talking to your colleagues. Also, the literature is a great source from my perspective about what's going on, what's working, what can you suggest bringing into your organization. Those kinds of things I think are very useful. So speaking up, using your voice, and keeping the lines of communication open is really important.
Great. Well, I just want to thank each of you for your time, your insight, and the really engaging discussion that we've had today about this critical issue. And I'll turn it over to David really quick to close us out.
Hey, thank you. It was a wonderful event. Thank you, everyone in attendance.
Thank you.
Thank
Thank you all.
you.
Bye-bye.
Thanks, everyone.
Thanks.